Okay, this skills video is assessment of an ankle. We're assuming this is a normal ankle, and just to give you a structured approach to what to look for. First thing obviously is presentation. Expose the joint as much as you can, and ensure that you compare it to the other side. It's very important. You might think, you know, this has got this ankle's thick, but then you look at the other side and see exactly the same. Very, very important. Next thing to do is to assess active movement. You really want to know what the patient can do, and so you ask the patient to dorsiflex. If you can just move your toes up towards your head, that's great, as hard as you can, and toes down towards the ground, that's great. And then back to the neutral position, thank you. And then can you move your ankle inwards, that, you know, inversion, and outwards please, eversion, very good, good range of movement. And then also we'll ask the patient to flex the toes down please, that's right, and then bring your toes up. Excellent, alright, all very normal. Once you've assessed the patient's movement, you might want to put the hand on the ankle as long as there's no pain. Ask the patient to tell you if there's any tenderness or pain, and then you ask them to just relax, and you do the same thing, and you're just feeling in the ankle joint for any crepitus or limited movement, and you can again invert and evert the ankle as well, and then just again toes down, assessing for any tenderness or pain that you might feel. Also very useful to just put a hand on top of the foot, the forefoot, and feel for crepitus, you know, that sort of crunching feeling in the tendons along here. If someone's got a tendonitis, you might feel that crunching feeling, which once you've felt it once, you know what I'm talking about. Also very important to be feeling for pulses. You're going to get one pulse just under the medial malleolus, and then the dorsalis pedis pulse across here, which is absent in a significant percentage of people. I'm not sure I can feel it in this. Oh yes, here we go. All right, no, we've got one. Yeah, patient is alive. Okay, an important thing to remember is the Achilles tendon. When you're examining the ankle, don't forget to just run your finger along the Achilles tendon. If you feel any gaps, tenderness or crepitus as you move, that might indicate either tendonitis or a tendon partial or full rupture. There are specific tests for that if you're considering that as a potential diagnosis. As you examine the ankle joint, don't forget there is a forefoot as well that we're going to examine in a moment, so I'll get to that. When you're examining the ankle itself, we've looked at movements. Now it's a matter of actually palpation of the lateral malleolus and the medial malleolus for tenderness and any abnormalities that you might feel. Now if you're looking at a fibular fracture, you might have a fracture a bit further up, and pushing on the lateral malleolus may not give you any pain. So a good trick sometimes is to squeeze further up in the calf on the side where the fibula runs down, and if you feel it or get the patient experiencing pain further down towards the ankle, that's not a bad sign of a disruption of some description, either ligamentous or bony pathology. So always a good one to test that way. Once you've palpated both the medial, lateral malleolus and around, and you've noted whether there's any tenderness or swelling, it's also always good to examine the forefoot quickly. The way you do that, just grab hold of the ankle, grab hold of the forefoot, and just twist, and you're really testing the tarso-metatarsal joints there for, again, any pain, tenderness, crepitus, and then have a quick look at the toes and make sure that no obvious dislocations or fractures. That's pretty much it. That's a fairly basic run through of an ankle assessment, and you may find other things that point you in the direction of further investigations. So once we've done a normal ankle examination or ankle examination, we have to decide sometimes whether or not we should be sending someone off for an x-ray for a suspected ankle fracture. So it's really difficult, and it's always case by case, and you always need to have a chat to the on-call doctor. But what I'd like to do is apply the Ottawa Ankle Guidelines, that's OTTAWA, because it gives us a framework to decide whether or not x-rays are needed or whether or not we can manage this conservatively. So up on the screen is the basics of it, but effectively what we're looking for is tenderness distally in the ankle around either malleolus, and in addition to that, the inability to weight bear. So that's what we need to get from you at the time of any call through to the on-call doctor. Is the patient able to weight bear, and how difficult is it? And is there tenderness anywhere around the malleolar region, and if so, whereabouts? And those things help us to make a determination of conservative management and just seeing whether or not we can strap and use RICE and see what happens over the next 48 hours or so, or whether or not we need to be sending that person off for an x-ray in the shorter term to see if there's a fracture. So if we use those guidelines, talk it through with the doctor, we should hopefully have a methodology that works across the CPA group.